Good morning, and thank you all for joining us. Before we begin, we would like to provide a land acknowledgement. As we gather here today, it's vital we remember the peoples who've gathered here for millennia. This is a Treaty 7 land of the Indigenous peoples of Southern Alberta, the Blackfoot Nations of Siksika, Piikani, Kainai, the Tsuut'ina First Nation, the Stoney Nakoda Nations of Chiniki, Bearspaw and Wesley, and the historic home of the Northwest Métis and Métis Nation of Alberta, Region 3. It is with the goal of reconciliation that we acknowledge the land on which we gather, and we thank the elders of these nations for their timeless contributions to this land. Part of our Kerby Centre Fall and Winter ongoing series of online health and wellness information, education, and entertainment presentations. We're very pleased to have the opportunity once again this year to present a month-long series of informative presentations on infectious disease, immunization, and staying healthy in body and mind, supported by an education grant from Sanofi Pasteur. It is our great hope that with the support of several renowned medical professionals, these presentations will help to provide you with the information that you need in order to make informed decisions about your health and wellness and to help you live your best lives. And today we're very pleased to welcome back our good friend Padmaja Genesh. Padma is a learning specialist with the Alzheimer's Society of Calgary with background in family medicine and gerontology. She's been with the society now for 10 years and has been presenting her valuable information regularly to Kerby Centre members every year since 2013. We've been very grateful for the valuable information and resources Padma provides to help us maintain our mental well-being. Padma, welcome.
Thank you very much, Colleen, for that introduction. And good morning and welcome everyone to the session on mild cognitive impairment. So first of all, thank you all for joining us this morning. We have lots of new territory to cover today. So without any further delay, I would like to get started. And I also welcome you to type in your questions in the chat box. Colleen has already acknowledged the land, so I'm moving forward with your permission. So the agenda, this is the agenda for today. So first, I will try to answer the question, what is mild cognitive impairment or MCI all about? And then I'll discuss the types of mild cognitive impairment, causes and risk factors for mild cognitive impairment. I will explain how mild cognitive impairment is diagnosed and treated at this time. Then move on to strategies for living well with mild cognitive impairment. So if you are diagnosed with mild cognitive impairment or you are experiencing some of the symptoms of mild cognitive impairment, here are some strategies for you to live well, and also strategies for slowing down progression so as that we can prevent the mild cognitive impairment from progressing on to dementia. Then I'll be sharing some resources for persons diagnosed with mild cognitive impairment and conclude by briefly, again, reintroducing to you the resources that are offered by the Alzheimer's Society of Calgary. So this is the plan for today. So let's move on. So what exactly is mild cognitive impairment? So the simple definition is it's cognitive decline that does not significantly interfere with daily living. So there is some cognitive impairment, so there is some symptoms, it could be memory loss, it could be difficulty concentrating or decrease in attention, it could be inability to think and make decisions or some language difficulties. But these cognitive symptoms are not that severe enough to affect daily living. That is what is meant by mild cognitive impairment. So the features are the person with a mild cognitive impairment would experience some cognitive concerns. And as I said earlier, it could be memory related or not related to memory. It could be something else, such as attention or decision-making difficulty or language difficulties or ability to concentrate and complete tasks. And at the same time, there is some evidence of cognitive impairment in tests. So it's not just that the person experiences some of these symptoms, some of these cognitive difficulties. Their performance in cognitive test is below the normal that is expected for someone of their age and education. So there is also some evidence of cognitive impairment in test. However, there is absence of functional limitations. That means despite these cognitive symptoms, the person is still able to carry on with most of the activities of their daily life for the most part. Okay, so even though there are cognitive symptoms and there is evidence in test, it is not started affecting the person's daily life yet. And that is the stage of mild cognitive impairment. When these cognitive symptoms start affecting the person's daily life, then we call it dementia. So we can see, if you can imagine that mild cognitive impairment as an intermediate stage between healthy aging and dementia. So you're in that mid zone where you can actually do something. That's the most critical stage, because this is the stage where we can actually do something to prevent dementia, to stop further progression. So that's why it is so important for all aging individuals, including you and me. Moving on to causes of mild cognitive impairment. So certain medications, those belonging to the class of anticholinergics and benzodiazepines, they are associated with cognitive impairment. The first group, anticholinergics, it includes commonly prescribed allergy medications such as Benadryl, certain antidepressants, certain sleep medications, and certain bladder control medications belonging to that group of anticholinergics. Benzodiazepines, on the other hand, they are usually prescribed as sleep medications or as sedatives. So examples are diazepam or Valium, lorazepam or Ativan. Those are examples of the benzodiazepines group, but these medications can cause memory concerns and other signs of symptoms of mild cognitive impairment. Metabolic causes. So nutritional deficiencies, dehydration and malnutrition, vitamin B12 deficiency, thyroid hormone deficiency, blood sugar changes, very high blood sugar or very low blood sugar, as what happens in diabetes, etc., can also cause mild cognitive impairment. Sleep disorders, examples, sleep apnea, where the person stops breathing while they are sleeping and the oxygen level in the blood drops, in the brain drops. So the brain would awaken that person, would alert the person, and they wake up and start breathing again. And sleep apnea has been found to be associated with high blood pressure, heart disease, dementia risk, and of course, mild cognitive impairment. Sleeplessness, insomnia or sleeplessness, chronic sleep deprivation, because of health causes or some other work causes or something like that. If there is prolonged chronic sleep deprivation, that can also cause mild cognitive impairment. Mood disorders such as depression and anxiety, mental health disorders such as schizophrenia, bipolar disorder are also causes for, they can also cause mild cognitive impairment. Sensory impairment, hearing impairment that is not corrected. As we age, we all can have hearing impairment, but the problem happens when we do not do anything about it. Okay, so hearing impairment, vision impairment, and if you are not doing anything to correct it. Some people have dual, both hearing and vision impairment, and that can have a much profound impact on the person's cognition. Neurodegenerative disorders. So early stage of Alzheimer's disease or any other type of dementia, that also is a cause for mild cognitive impairment. Now, looking at the prevalence of a mild cognitive impairment, it's common in older populations, and the prevalence increases with age. Okay, so if you in the age group of 60 to 64, about 7%, maximum of 7 up to 7% of adults in the age group of 60 to 64 can develop mild cognitive impairment. 15 to 20% of adults in the age group of 65 and over. And when you look at older age groups like 90 plus, over 37% of adults in that age group can have mild cognitive impairment. So just as in the case of dementia, the prevalence, it's more common as we age. Moving on to, but however, I have to go back to the previous slide and say that even though the risk increases with age, it is not a normal part of aging. Okay, that is something that we need to remember. So looking at the subtypes, the different types of mild cognitive impairment, mainly it can be broadly classified to amnestic variety and non-amnestic. Amnestic is where memory is mainly affected. So the person is experiencing some memory concerns, nothing else, it's just some memory concerns. So that is amnestic MCI. And the other group is non-amnestic. Their memory is intact, but they are finding some other difficulties like getting easily confused or decreasing attention, getting lost in familiar surroundings, etc. Losing their way, those kind of things. That is non-amnestic MCI. Then the amnestic mild cognitive impairment itself can be either single domain, just the memory is affected, everything else is normal. Or it can be memory plus something else, multi-domain. So in a single domain where just memory is affected, that kind of MCI is found to be associated with a higher risk of developing Alzheimer's disease. So just that memory alone, and that is a risk of progressing to Alzheimer's disease. The other category is memory is affected as well as something else, something else, some other cognitive concerns also they have. That is multi-domain amnestic MCI. Amnestic means memory is a significant part, and that is associated with a higher risk of developing mixed dementia, Alzheimer's disease and vascular dementia that is due to stroke. So combined, okay. Now the other variety, non-amnestic MCI. So there is no memory symptoms at all. It is some other symptoms like attention, recognizing familiar surroundings, orientation, etc. If that is affected, or language, if those are affected, that again can be single domain where just one of these features is affected, or it can be multi-domain where more than one aspect of cognition other than memory is affected. Okay, and such individuals, this kind of non-amnestic MCI, whether it is just one area or multiple areas, that is found to be associated with a higher risk of developing other types of dementia, like frontotemporal dementia, dementia with Lewy body, and Parkinson's disease dementia. So this is the basic classification of mild cognitive impairment. Moving on to symptoms of mild cognitive impairment. So amnestic MCI, where we have the memory symptoms. So similar to symptoms of dementia, forgetting appointments, forgetting conversations, forgetting events, etc. But there's a possibility that when the person is reminded, they are remembering that. Okay, so with some clues or reminding, the person recalls that, okay, yes, I had an appointment I missed. Whereas that doesn't happen in the case of someone with dementia. Non-amnestic, where it is not memory related, the symptoms could be language difficulties, so difficulty engaging in conversations, finding words. It could be attention deficits. So then the person is not able to concentrate, focus and complete their task. So they are leaving task incomplete. Thinking can be affected sometimes for some people. So that leads to difficulty making decisions on a daily basis. Or for another person, it could be spatial. It is, they are that disorientation. They are not able to recognize familiar surroundings and finding it difficult to go to places, get to places, okay? So that is the amnestic and non-amnestic MCI symptoms. Then MCI can also be associated with other symptoms like poor concentration, anxiety, and depression can be a feature. Apathy, that is losing the drive or initiative to do things. Irritability and depression. So these are some of the other symptoms associated with MCI. Now, you might be wondering that, okay, what is the difference then? People who are aging in a healthy way, they can have some of these symptoms as well. People with dementia can have these symptoms. So what is the difference? How do we distinguish? So I'm giving you a comparison between symptomatic comparison between healthy aging, MCI, and dementia. So people who are aging in a healthy way, they sometimes forget words, but after some time, they remember that automatically, spontaneously, they remember it. Losing things sometimes, but again, maybe in a day or two, they will recover those things. They will find those things again. They are able to retrace their steps back and retrieve those things that were presumably lost. They are able to find that themselves. Missing payments occasionally, but again, remembering that, oh, I forgot to pay this bill. Spontaneously, they are remembering on their own, and that is healthy aging. Okay. When it comes to MCI, difficulty coming up with words, routine conversations, simple words that the person is using, they are having difficulty getting those words, and losing things often. And that is a feature of both MCI and dementia. But with persons with dementia, it is lost forever. What is being misplaced, they are misplacing things and they're not able to find it. But for someone with MCI, when they are cued, when they are reminded, they are still able to, find things. So not themselves by themselves, but when somebody is reminding them where it could be. Missing important appointments, that is again true for both MCI and dementia. But as I said in the previous slide, people with MCI, when they are reminded, they do remember, okay, yeah, sure, that's true, I had an appointment, I missed it. Whereas persons with dementia would categorically deny, having that appointment at all, because that's not in their memory at all. Trouble having conversation, reading, writing is more common. All those aspects of daily living more common in dementia. Repeating, the tendency to repeat oneself, asking the same question again and again, that's a feature of dementia, not seen much in MCI. Problems handling money, getting lost. It's not just confusion, it's getting lost. People with MCI might get confused, but they're still able to find their way, but getting lost. And hallucinations, experiencing things that are not there, seeing things that are not there, smelling things that are not there, hearing sounds that are not there. That's more a feature of dementia. Delusions, having very strong beliefs which are false. That is also a feature more of dementia. No, it's not a feature of MCI or healthy aging. And paranoia, so suspicions about people around them, about things that are going on around them. So all those are features of dementia. So I hope this comparison helps you kind of, tease them apart to some extent. Risk factors for MCI. If you're talking about risk factors for MCI, they are very similar to risk factors for dementia. So advancing age is a risk factor. Having a family history of stroke or any type of dementia or Parkinson's disease, that's a risk factor for developing MCI. Risk factors for stroke. If you have risk factors for stroke, that is high blood pressure, that's not controlled, diabetes, obesity. If you you have a personal history of excessive smoking or excessive alcohol consumption, if your lifestyle is sedentary, not much of physical activity, then all those are risk factors for MCI. Low education level, that is a risk factor. And also if you have been doing, say you have been working, but the kind of jobs that you have been, your employment has been basically assembly line jobs or mechanical things that you do without giving too much of thinking or using the brains, then that is, those are all considered as risk factors for MCI. Also having diabetes, high blood pressure, etc., that's not controlled. Sensory impairment. When I talk about sensory impairment, it is hearing impairment that is not corrected, vision impairment. People do take care of their vision, then they wear glasses, but many of us are kind of hesitant to use hearing aids, but that can be a risk factor, definitely. depression, anxiety, depression, mental health disorders, sleep apnea, and sleep disorders. So you can see that the causes of MCI and risk factors are more or less same. A lot of overlap there. Moving on, course and prognosis. So what is the course for someone who is being diagnosed with mild cognitive impairment or someone who is experiencing those symptoms? What happens? So with time, persons diagnosed with MCI, they may remain stable. Some people remain at that level. Maybe they had something happen and then some health condition happen, and that may be a stroke. And now they've been taking excessive, lot of care, aggressively the following lifestyle interventions to reduce further strokes, so they can remain stable at that level. It can improve if the person has actually, figured out it's a treatable cause maybe, and they have figured out what is the cause and they have been working on it, treating it, and now they can improve. Some people can improve, but if it's been due to early dementia and we have not been diagnosed, the person has not had a diagnosis, has not had a chance to engage in lifestyle interventions, then they may even progress to dementia. So if the mild cognitive impairment is from treatable causes that we talked about, let's say vitamin B12 deficiency, thyroid disease, depression, or maybe an infection that is causing confusion, things like that, then when these conditions are treated, MCI, their cognition improves. But if it's due to early degenerative brain changes, early changes of dementia, and then there's a chance that they might progress to dementia. And every year, about 15%, those who are diagnosed with MCI or those people living with symptoms of MCI, about 15% of them above the age of 65 can progress to dementia every year. So this is how it progresses. But again, as I mentioned here, as I very clearly again repeat here on the slide, early intervention at this stage can slow down cognitive decline. So rather than getting diagnosed with dementia and then trying these strategies, you have better success if at this stage of mild cognitive impairment, if we can really adopt intervention strategies, we have a much better luck and success in preventing progression to dementia. So that's why this stage is so very critical. So this is showing the natural course of cognitive decline in mild cognitive impairment. So this graph showing the age in years in the x-axis, on the x-axis, and the cognitive function on the y-axis. And just give me a moment. I want to just pull out my pointer because I want to show you point out the trajectory. So for people who are aging normally, they begin with this, they have this high level of cognition, and it remains more or less the same, until the very end of the life when there is some dip in their cognition, but still they are above the level of mild cognitive impairment. So this is a trajectory for normal aging. But for someone who is going into MCI and dementia, they have a different trajectory. For up to the large part, they are kind of normal, but then after the age of 60, 65, they start following a different trajectory. So there is this initial period, which is called preclinical period, when there are some changes happening in the brain. Degeneration is happening in the brain, but the person has no symptoms at all. And that is known as the preclinical period. And this can be anywhere from 15 to 20 years, because that is how long it takes for all the plaques and tangles of Alzheimer's disease to develop in the brain. And during that time, there are no symptoms, okay, preclinical period. And then the first time they notice some changes when they are at this stage of MCI. So there is some symptoms, and also that's showing in some tests. And that is the stage of MCI. And this stage can last for anywhere from 5 to 10 years based on the efforts, the intervention strategies that you adopt. And if nothing is done at this time, then the person progresses on, follows that trajectory down, their cognition is dipping down, and they're going down to the level of dementia. So this is and this stage of dementia can last anywhere from 8 to 15 years on an average. Okay. So this is the natural course of cognitive decline. So now moving on to, now that we have studied about, we have learned about what is MCI, what are the different symptoms, memory related, non-memory related, what is the course it takes, what is the prognosis. We are going to talk about how MCI is diagnosed. It's mainly a clinical diagnosis, and diagnosis is based on detailed history from the person. So if you are worried about, if you are experiencing some of these symptoms that we talked about and you're concerned about it, the thing to do is, what you need to do at this point is kind of note it down and talk to your physician about it. Bring it up to your physician and say that you're worried about this, whether you might be having this mild cognitive impairment. Then your physician will take a detailed history to find out, any changes, what kind of change you have observed in your memory, in your language, in your conversation, communication ability, in your attention, in your ability to do tasks, etc., and including assessment of independent function. So how are you carrying on with the activities of daily life? How independent you are. So that's one part of the diagnostic process. And then the physician would want to do an interview with a family member because sometimes the person might think that they are doing everything independently, but a family member might say that, no, I've been pitching in and helping in these areas. So that is an indication that maybe it's possible that the person has passed this MCI stage and is progressing on to early dementia stage. Assessment of cognitive status. So cognitive assessment, the usual cognitive assessment tests are MoCA and MMSE. But when it comes to MCI, MoCA is more sensitive for picking up mild cognitive impairment than MMSE. It's a questionnaire and it's scored out of 30. And a score that is below 26 is suggestive of mild cognitive impairment. Then there's and if that test is showing like indicative of mild cognitive impairment, detailed neurological exam. So to see if there's been any other, any other diseases affecting your nervous system. So whether you had a previous stroke that has not been diagnosed. So all that detailed neurological exam will be conducted. And that's usually done by, could be done by a geriatrician, or sometimes a physician might refer you to a neurologist. Blood tests for treating treatable causes. So this is to look out for all the treatable causes of mild cognitive impairment that we talked about. So vitamin B12 deficiency, thyroid function, then kidney function, diabetes, blood sugar levels, all that, okay? Detailed neuropsychological testing. This is to assess your detailed testing of your memory, language, your attention, your focus and your ability to complete tasks. All that is mood, and your thinking pattern, all that. And this is to rule out, to have a better idea of what kind of cognitive abilities you have lost or are declining, and also to pick up depression or even signs of delirium or confusion from any other physical condition that you might have, like an infection. Imaging is not really required, not always required. It's not mandatory. It's only where there's a confusion about the diagnosis that the physician might send you for an MRI scan or a PET scan. That's not really required most of the cases. If there is a suspicion, they're not really sure whether you have mild cognitive impairment, and the physician thinks it might be due to stress in your life or some other things, some traumatic events happened in your life. And then the physician might decide to monitor you periodically and assess your cognition. And if Alzheimer's disease is suspected, especially if it's in a younger person below the age of 65, there is a family history of Alzheimer's disease, then the physician might send you for genetic testing for one of the Alzheimer's disease genes. Okay, so this is that 1% of Alzheimer's disease that is due to one of these defective genes and get passed on from one generation to the next. So basically the three genes, presenilin 1, presenilin 2, and amyloid precursor protein gene. And this is usually done only for young people below the age of 65 and who have a family history of Alzheimer's disease. Then if there is a suspicion that it is again MCI due to Alzheimer's disease, if there's that suspicion and it's a younger person, then some neurologists do, before they confirm the diagnosis, they might want to look for some amyloid, the Alzheimer's disease changes in the brain. So looking for abnormal proteins in Alzheimer's disease, which is beta amyloid and abnormal tau. So this is an what you call invasive process, because it's by doing a spinal tap and looking at the levels of these proteins in the spinal fluid. So looking for changes in that. PET scan for amyloid, not usually done here, only for research purposes it's done, the PET scan for amyloid. But what is more commonly done, if there is a suspicion of the diagnosis, then that's an MRI. The person might be sent for an MRI to look for changes in brain volume. So if it is due to dementia, then brain is shrinking. So looking for that changes in the brain volume, and also looking at glucose utilization by the brain. And that is the FDG PET scan. Okay. So we have some images here. So this is the normal MRI scan, healthy older adult. So there is no shrinking. The brain is very densely packed. And this is like if you take a section like this, from the front to the back like that, if you take a section of the brain like this, cutting like this, okay, to the front to the back. So this is the front of the brain. This is the back of the brain. You can see that it's very densely packed. There is no much space anywhere. That's normal. MCI, you see that it's not that densely packed. There are spaces here and there. That is true. There is some space here at the rim too. So showing some little bit of shrinking of the brain, might be from Alzheimer's disease. And when it is Alzheimer's disease, you will see there is more, there's more spaces everywhere. The brain is much less densely packed. And amyloid scan, this is the amyloid PET scan, not usually done except for research, in that this is a healthy brain showing very little amyloid. Here, amyloid is showing up as these red patches here. So very little amyloid. That's a healthy brain of an older adult. And here you see more of those red patches. So that is showing amyloid deposition. But again, many people can have amyloid, but they may never develop Alzheimer's disease, but they can have some cognitive impairment still. And this here is a tau PET scan. It shows the abnormal tau in Alzheimer's disease as these streaks here. And that indicates, and these tau in the brain is indicative. It correlates very well with our cognitive status. But again, it uses radioactive isotopes, so usually not available everywhere. But what is done here in Calgary basically is a MRI scan if there's a doubt of diagnosis, and also the glucose PET scan. And glucose is a fuel for the brain. Our brain uses, a healthy brain uses glucose all the time because of all the activities that the brain is doing. And this is a normal glucose PET scan. You see this here, the red is showing the glucose utilization. So glucose is being utilized uniformly all over the brain. That's a healthy brain. Mild cognitive impairment, there are some areas where it's pale. So that's just telling you that, glucose is not being utilized. So cells are not functioning normally. The brain is not, there is some cognitive decline there. So that's what it shows. And in Alzheimer's disease, you will see that there are a lot more areas, many more areas where there is no uptake of, there is no glucose utilization at all. And that is an Alzheimer's disease brain. Okay. So I hope this is clear. But again, I want to tell you that, reiterate that diagnosis is mainly clinical diagnosis. The imaging or scanning is not required on a regular basis. Now moving on to management of MCI, how MCI is treated. The first step is to review the medication list, and see if the person is on any medication that could compromise their cognition. So we talked about the benzodiazepines, the anticholinergics. So I am trying to identify if the person is on any of those medications, and then substituting. If the person really needs those medications, giving a different substitute that does not affect the cognition. Then depression and delirium screening. So that's very important because depression can also cause some cognitive impairment, and it's a treatable condition. So screening for depression and delirium, which is a state of confusion associated with infections like pneumonia, flu, etc. And prescribing treatment, appropriate treatment, including counseling for depression. Then you'll be sent for sensory screening and correction. That is your visual assessment of your vision and hearing, and advising, giving you corrective strategies, corrective devices for improving your vision and your hearing. A sleep study, if it's suspected that you might be having sleep disorders or sleep apnea. So perhaps you are sleeping well at night, but when you wake up in the morning, you're still feeling very exhausted, not feeling rejuvenated, you're not feeling energized. Then, or maybe your partner is complaining that you're snoring too much. And then if that's the case, then you might be tested for sleep apnea and other sleep disorders and, corrective measures. Sleep apnea is a condition that can be very well treated using that CPAP machine, that you fix over a mask, and then oxygen, you're breathing in oxygen. So that is a very good, very successful way of treating sleep apnea. Then control of cardiovascular risk factors. So if you have high blood pressure, diabetes, or a high level of cholesterol, then medications and other lifestyle strategies to correct that. Screening for behavioral and psychiatric symptoms. So if you have mood disorders and things like that, screening for those and treatment. Cognitive training interventions. This is usually provided as part of stroke rehabilitation. But for others who are not, if you do not have a history of stroke, then these are things that we might have to figure out, or, seek the help of a occupational therapist, or your physician might send to someone in the primary care network, an occupational therapist. Or you might have to find your own online strategies, online cognitive training programs online. Risk reduction strategies are also advised to slow down progression, because as I said earlier, this is the stage we can do something to prevent progression to dementia. Then supports strategies for the person to live well with cognitive impairment. Caregiver education and support is also very important. And also everyone diagnosed with mild cognitive impairment, or a person who is suspected of having mild cognitive impairment, is asked to return again to the physician for periodic review and monitoring. That's very important part of the management. So these are the medications that are that can affect cognition, and it's better to avoid these medications. So if you are on any of these anticholinergic medications, you will be asked to discontinue, stop those medications, or use a substitute. Okay, Benadryl, certain depression medications, sleep medications, etc. Opioids, if you're been taking that, then that can affect cognition. So you'll be asked to kind of wean away from that gradually. Sleep medications like benzodiazepines, if you're on any of those benzodiazepines, then you are either given a substitute and asked to wean away from this medication. Antipsychotics, if the person is on any behavior modifying medications, then that can impact cognition. So you'll be asked to, your physician will give you a substitute, or ask you to stop taking those medications. Certain blood pressure medications, especially beta blockers for some people, methyl dopa and reserpine, can affect cognition. So if you are on these medications, you'll be given a substitute, another blood pressure controlling medication. Antivirals like interferons, HIV medications are also, they can affect cognition. So those will be, you'll be asked to, may either reduce the dose, or do some other treatment, provide some other supportive treatment. So some people can be on nervous system stimulants like dexedrine, dextroamphetamine, or maybe methylphenidate, so especially those who have excessive daytime sleepiness. So those medications can sometimes affect cognition, and you'll be advised to stop taking those. But the thing to understand is not everyone on these medications are affected, because each one of us is a different, unique individual, different set of genes, different lifestyle, different other health conditions. So it is unique for each person. Moving on to treatment of MCI, there is no approved medication to treat MCI at this time in Canada. In United States, a new medication, Aduhelm, has been conditionally approved. It was just in this June that it was approved for mild cognitive impairment due to Alzheimer's disease and early Alzheimer's disease. This drug was initially studied under the name of aducanumab, and in the last final stage of studies, they conducted 2 studies all over the world. Even University of Calgary was a site, and in one study it showed some benefit, but the other study it did not show any benefit. And also this drug has to be administered intravenously, and also under MRI, it has to be administered under MRI. Why? Because it can lead to swelling of the brain, which can be fatal for some people. And also, so that's one of the side effects of this treatment. And also it is quite expensive, $56,000 per year. So Health Canada has not approved it yet, and they are asking for more evidence, So the studies are continuing now. Even in US, it's a conditional approval. So they have to conduct further studies and show that, okay, this is working. Then only it can be, otherwise its license can be revoked. So basically, no medication to treat MCI at this point, no approved medication. And even the Alzheimer's medication, it's not found to have any conclusive benefit. There is no strong evidence of benefit in using Alzheimer's medication like Aricept. However, some neurologists, some specialists do prescribe it, especially if it is the mild cognitive impairment is due to early Alzheimer's disease. They do prescribe it, but then informing the person that it's possible that there may not be any benefit. Okay, but we will give it a try. And these are the medications: Aricept, rivastigmine, galantamine. These are all the routine Alzheimer's medications. They may be prescribed off-label. Then antidepressants is always tried, and it's found to be very helpful because, as you can imagine, when a person is experiencing these symptoms, depression is a feature of that. And therefore, antidepressants can usually help and improve the person's symptoms quite significantly. And even if the person has mood and behavioral symptoms, it is the antidepressants that are given, and they are found to be effective. Very safe antidepressants have citalopram, escitalopram, venlafaxine, duloxetine. These are the ones that are tried. And then another part of the management is making sure that the person's blood pressure is brought down to the level that works for them. There's the standard protocol is the systolic blood pressure, the higher value to be 120 for people below the age of 65. And for people above the age of 65, the minimum you can bring it down without causing dizziness, okay, or risk of falls. So medications to control high blood pressure and cholesterol and diabetes. Medications to control infection if delirium is suspected. So that's the medical aspect of the management of MCI. Then cognitive interventions. So cognitive interventions are routinely provided for people who have had a stroke as part of their stroke rehabilitation program. Okay, so one type of cognitive training given is the restorative cognitive training. So it involves, first of all, identifying what cognitive skills have been lost because of the stroke, and helping the person develop those skills through practice and memory strategies. And they will also be given some computer-based training, using some computer programs to improve their short-term memory, attention, problem-solving skills, etc. For people who do not have a history of stroke, then we may not have access to this, but we can, through our physician, we can, we might have to pay for it. We can seek the with the help of an occupational therapist who can help us with the same kind of cognitive training. And for language difficulties, a speech language therapist can also help. Then the thing that we all can do is, engage in a variety of cognitively stimulating activities. So doing puzzles, trying to learn a few words of a new language every single day, all those, and playing games that can stimulate the brain. So brain exercises and games to stimulate multiple aspects of cognition. So a lot of online programs are available like Cognifit, BrainQ, etc., but they are not free. So that's a sad part. So we have to kind of come up with, playing games and things like that, doing puzzles, things that don't cost us, but still are equally effective. Supplement with physical activity and social activity. That is when it is beneficial, found to be ideal to combine with physical activity and social activity. Environmental modification can help. This involves using some assistive devices. For example, people who have walking difficulties, using some walkers and things like that. Speech difficulties, using some communication devices. Even other things to make daily life easy. For example, blister packs or pill reminders, pill dispensing devices. It could be alarms on your clock, on your cell phone, or alarms on the stove, automatic shut off taps and showers. So those kind of things can make everyday life easier. So it reduces cognitive load and also helps us to carry on with activities of daily life. So that's the aspect of cognitive intervention part. There is some research to show that those strategies are actually beneficial, along with other lifestyle strategies. So that's what we are going to talk about now. First, we will talk about some memory strategies if you are having some memory impairment. So simple things like establishing a routine. So you follow the routine, you make sure that you're doing all that you're supposed to do on a daily basis. Keeping things in the same place, labeling them, and reducing clutter helps you identify things that you need. Grouping things together, keeping things together in one place that you would need. So in the morning, like your coffee mug, toothbrush, toothpaste, and your pills, so that you do all that at that time. You remember to do all that. And engaging in mindfulness, so being mindful all the time, where you leave your things, being mindful. Using calendars, electronic calendars, diaries, checklists, smartphone, medication dispensers, as I said, alarms on stove, timers, etc. If there is some big task to be done, breaking it down into a smaller task might help you get them done. Otherwise, a big task might look very overwhelming. Focusing on one task at a time. So if we have any cognitive impairment, mild cognitive impairment, multitasking will not work for us. We'll have to focus on one task, finish it, check it off the list, move to the next one, and so on. And reducing distractions, so radio, television, and all that can help us focus on our task. Now, strategies to slow down MCI, progression of mild cognitive impairment to dementia. And this is all based on new research. So this poster has been developed by Alzheimer's Disease International, and it is based on the Lancet 2020 report of the Lancet Commission on Dementia Prevention, Intervention, and Care. They've identified 12 modifiable risk factors. And this is very important for anyone diagnosed with mild cognitive impairment or experiencing mild cognitive impairment, to make sure that we are, we are tackling all of these. Okay, so physical inactivity is a risk factor. Smoking, excessive consumption of alcohol, air pollution. We cannot do much about the air being polluted, but we can stay indoors when the outside air is of poor quality. Head injury, so making sure that to prevent head injury. Infrequent social contact, so rather than being isolated, using technology to connect with people and staying socially connected. Less education is a risk factor, So keeping on challenging the brain, learning something new all the time, that helps. Obesity is a risk factor. High blood pressure, hypertension is high blood pressure. Diabetes, depression, hearing impairment. So these have been recognized as the 12 modifiable risk factors. By addressing these risk factors, 40% of dementia can be prevented. Okay, so we can reduce our risk by 40%. So 40% of dementia is caused by these risk factors. So that can be, we can minimize that risk and prevent it. So can dementia be prevented? Researchers are saying yes. Okay, and these are the strategies that they are suggesting. So minimize diabetes, treat high blood pressure, prevent head injury, stop smoking, reduce air pollution, or at least stay indoors, reduce midlife obesity. This can help to reduce brain damage from amyloid, from abnormal proteins, from stroke, from inflammation. Combining that with frequent exercise, reduce depression, and avoid excessive alcohol, then we can, that can also help with reducing the brain damage from all these factors, so amyloid, stroke, and inflammation. If you add on, by adding on other strategies like treat hearing impairment promptly, maintain social connections, continue lifelong learning. So combine that as well, and then you can improve your cognitive reserve. So cognitive reserve is the capacity of the brain to function normally in spite of having age-related shrinking of the brain or any degenerative changes in the brain. That is what is meant by cognitive reserve. So these strategies here help us in building a high cognitive reserve, so that even if these changes start happening in the brain, we are still able to function to a large extent, function normally to a large extent. So together we can therefore reduce our risk of dementia. Moving on. So these are the strategies here to slow down progression, treating high blood pressure. As I mentioned earlier, for people below the age of 65, strict control of systolic blood pressure to 120. So when you have your blood pressure reading, you have say 140 by 90, something like that, or 130 by 90. That top value is called the systolic blood pressure, okay? So bringing that down to 120 in people below the age of 65. Very effective in preventing dementia. And for people who are above the age of 65, bringing it down to the minimum that is possible without causing dizziness. Moderate intensity aerobic exercise, 60 minutes daily or 30 minutes twice daily. It can be simple things as walking, as we see here, walking. Online cognitive training, or engaging in a variety of cognitively stimulating activities, such as puzzles, learning a few words of a new language, enrolling in a course, learning to play a musical instrument, learning any new skill or hobby. Diet. So eating healthy, plant-based diets, such as following a Mediterranean diet, which is based on vegetables, whole grains, fruits, nuts, oily fish, olive oil. We've been talking about the Mediterranean diet years ago, but still that's still showing, holding very good. Reduce obesity and diabetes through healthy diet and exercise, treating sleep apnea, aim to get adequate sleep at night, assess and treat hearing loss, avoid alcohol, and quit smoking. These are the ways to prevent progression, to slow down progression and prevent dementia. Avoid head injury, staying socially connected, reducing stress. So whatever works for you. For some people, Tai Chi. For some others, music. Playing music, listening to music. Group singing, choir singing, found to be very, very protective for the brain. Arts, pets, engaging with pets, interacting with pets. Outdoor nature-based activities. This is new research showing that people who have access to outdoor, like park, community parks, etc., they report less of depression and anxiety. And routinely engaging in outdoor nature-based activities is found to improve one's cognition. Okay, so that's all new research. Moving on. Finally, talking about the resources and support. So if you are a caregiver caring for someone with mild cognitive impairment, the most important thing to do is learn about this topic, learn about this condition. You can contact the Alzheimer's Society of Calgary for education about this condition, information about resources that are available and supports that are available in the community, how to navigate the healthcare system to access programs and services, planning for the future, and self-care, how to take care of yourself as well as building your support system. And also joining a support group. These are things that you will get help from the Alzheimer's Society of Calgary. You can contact us for any of these. Here is a list of resources, and I have sent this to Colleen. She will be sending the information on these slides to you. So lots of resources here, very helpful, very good information, very current information. Now concluding, to conclude, mild cognitive impairment refers to cognitive decline that does not affect daily living. People with MCI, they can either stay stable at that level, their symptoms can improve, or they can progress to dementia. Diagnosis is based on history, blood test, cognitive assessment, functional assessment, scans, not always required, but lab test, of course, blood test. There are no approved medications for treating MCI at this time. But as I said, 40% of dementia is due to preventable modifiable risk factors. And there is significant evidence that by using multiple interventions, you can actually prevent dementia from happening, or at least even slow down progression. So cognitive training, memory strategies, treatment of depression, hearing and vision improvement, counseling, all can be beneficial to slow down progression. Multiple lifestyle strategies. The idea is not just to focus on one, but include all of them. That is where we get the benefit. Okay, so exercise, diet, cognitively, engaging in cognitively stimulating activities, etc. All can help slow down progression. And it's always best to one size fits all doesn't work when it comes to medicine. So it's always good to approach your physician and have the physician assess your individual risk for developing the condition for MCI and dementia, and then work on it. Have that personalized, individualized approach, prevention approach that is found to be most beneficial. Okay. This is about what we provide. So Alzheimer's Society of Calgary can be the education and support hub. We have a team of social workers who will answer your questions. They will help you navigate healthcare system and access programs and services that are beneficial for you. They will connect you with resources that are available in the community. They can help you problem solve and deal with the everyday activities, everyday challenges of caregiving by listening to you patiently and helping you problem solve. We also provide education, evidence-based education, as this webinar, and also several other webinars that are also presentations by physicians that we have on a monthly basis. And our website has got a lot of current information, videos, etc. We run day programs through Alberta Health Services to provide opportunities for persons living with dementia to engage meaningfully and also to have that social connection. And that also gives respite time for caregivers. So please do check out our website for more educational sessions that we do offer on freely to the community. And please call us if you need any support or education, anything from us. If you have a question, please do not hesitate. Help is just a phone call away. Just pick up the phone and give us a call, and we promise that you will get all the help that we need. So big thanks to all our sponsors, Gordie Howe Cares, United Way, Calgary and area, and Alberta Retired Teachers Charitable Foundation. And I have an evaluation link here. I'm just going to copy it and paste it in the chat box. Colleen will send them to you as well. But if anybody wants to complete it right away, I'm going to post it in the chat box. And thank you all for listening, and I'm going to look at the questions here.
And we have some questions here in our Q&A.
Mhm.
Maureen has said that was very informative, thank you. Did not realize that MCI did not inevitably lead to dementia. This needs to be better known. I wish I had known the MCI and some of the interventions and treatments years ago when I started to suspect my late husband, who died from a totally unrelated illness, was experiencing some of the symptoms you laid out. I was worried but had no idea what to do, especially when he denied he had problems, and then for you to give us options here as far as helping to stave it off, that was great information. Thank you very much.
Welcome. Someone says that they couldn't hear me. Did you have problem hearing me, Colleen?
No, I heard you just fine. There's just a quick question here in the Q&A, and then I'll go to chat because that may have been in chat. Louise has asked, what is the black part of the AD brain?
Oh, okay. Yeah, in that picture. So that is just the cavities in the brain. That is, can I pull that slide up again? There, see, that option comes only when I have the slideshow. So this must be the black part that you've been talking about. That shows that that's an empty space. Here you can see the brain is so thick. This outer part of the brain is called cortex. That is so thick in a healthy brain. And again, same level of thickness is there in mild cognitive impairment too. But when it comes to dementia, do you see this space in the middle? That is big. That's looking very big. Why? Because the brain has been shrinking. Can see the shrinking of the brain. So that's what it shows, empty space in the brain because the brain is shrinking. Okay, the cells are destroyed. So I hope that this answers your question. Can I stop sharing?
Sure. If you still need further clarification, just message us back here. I'm just going to go into chats here, mostly accolades here for great presentation, and thanking you for such great information. I was looking for the person that had problems with the sound, but I'm not seeing it here. So hopefully that person was able to rectify the situation. If you have any problem, then hopefully you can revisit the recording afterward, and hopefully no one else experienced a problem. The powers of Zoom, who knows?
Yeah. Any other question, Colleen?
Yeah, Pauline has said, what type of puzzles do you suggest, especially if a person doesn't like jigsaw puzzles?
Yeah, it's based on, what area of cognition is being affected. So if the person is having some memory issues, so some games that will help them remember things. So for picture matching, you first open all the pictures and then see it, some tiles, pictures on the slides. Then you kind of reverse the tiles and then try to figure out where that picture is. So something to do with that basic skill that is being lost, or there's a decline, whichever ability is lost. If it's got to do with attention, so games that will focus on, puzzles that will focus on those kind of things, force you to become more attentive, to develop those skills. So it's based on what is being affected. If it is word, the person is not getting words, then word games would be ideal for such a person. If it is difficulty with numbers, then number games, so kind of figuring out where exactly is that deficit and try to find out appropriate games for that. Your physician can help. If you talk to your physician can connect you with an occupational therapist, and they can help you with those strategies as well. Okay.
For those of us that have grandchildren, there's some great games that you play with your grandchildren that are memory games.
Yeah.
That you're doing dual purpose. Jean has asked if you could talk about gut health and its relationship to Alzheimer's.
Sorry, say that again.
the relationship of gut health to Alzheimer's?
Gut health, yeah. So there has been some research about the gut-brain connection. So it's believed that certain bacteria, especially in the guts of persons with Alzheimer's disease, what we are seeing is the bacteria in the intestines is much different, very different from the bacteria that you find. We all have, healthy people have bacteria in the intestines, and that help us digest the food and all that. That's normally there. But persons with Alzheimer's disease have a different set of bacteria. And it is believed that these bacteria release certain chemicals that can increase inflammation in the brain. And those inflammatory chemicals can travel all the way from the gut to the brain, and that is driving the dementia process forward. Okay. So that is a gut-brain connection, and there's lots of research showing that there is a very strong feature of, that could be a very strong contributing factor for Alzheimer's disease. And the same connection is also made with the bacteria in the gums. So a particular type of bacteria called Porphyromonas gingivalis, that releases certain chemicals again in the mouth, and again that's carried all the way to the brain, and that can drive that inflammation. That even if it's initially there are just some plaques in the brain, it can make that because of inflammation, it can make more plaques and tangles accumulate in the brain, and can drive the process of Alzheimer's disease forward. I hope this answers your question.
So not only vision and hearing assessments and keeping on top of that, but dental care, I think.
Yeah, absolutely. Yeah.
What's just curious also with the correlation between ADHD, and Alzheimer?
Yeah, there is some initial kind of research showing that, some literature showing that there could be there could be a connection, association between ADHD, especially it may not lead to dementia as such, but it can lead to cognitive impairment. So ADHD definitely has been found to be associated with cognitive impairment, mild cognitive impairment. Mm-hmm. And if the person has got other factors like high blood pressure, diabetes, cholesterol, things like that, then it sets the stage for dementia, to happen. So there is some connection. It is showing that even learning disorders in childhood, showing that the brain is that at that point itself, brain is showing some deficits there, and that can, as the person grows, that can increase the risk of cognitive impairment if we do not aggressively, adopt strategies or interventions to slow down the progression.
You mentioned head injury, maybe people that had concussion or something.
Yeah, absolutely. Yeah.
Years. And you had me a little bit concerned about the topic of blood pressure, mm-hmm. and how important it is to stay on top of the blood pressure, but then on the flip side, some of the medications can cause you a problem. Is there any medication that is better than others to?
No, okay, thank you. The medications that were on the screen that were shared, that is beta blockers, then methyl-dopa and reserpine. Methyl-dopa and reserpine are not usually prescribed at all. Used to be in the past, but there is more recognition of or awareness about their side effects, so that they are not generally, you will not see those medications in your medication list at all. But some people are on beta blockers. But again, as I said, if there's a suspicion that the cognitive impairment could be due to that, then you could bring it up with your physician and switch to a different group of blood pressure medications. There are so many different groups. But again, having said that, that last statement on the slide was not everyone on these medications are affected, doesn't mean only some people, because as individuals, we are susceptible to different things. So that individual variation is there. Okay, not everyone gets affected by those medications.
Barb, it is difficult to assess information and support of MCI and Alzheimer caregivers who live in rural areas. Are there any resources for someone in the rural areas?
Yeah, that is true. It is, but this, since the COVID, it became involved in our lives, became a feature of our lives. More of resources and support are available online. Okay, so that is where you could, even if a person is living in a rural area, but you can still connect with the Alzheimer's Society, and we are able to provide resources and support. Actually, some of our sessions that we do have been attended by people who are in United States, in United Kingdom, Singapore. We have gone international. That is what the COVID has. One of the benefits of COVID is that reach, that international reach, so that you can still access our services and programs and contact us for help. You do not have to be living in Calgary and area. So many people provide those online resources as well, so they are accessible.
I know we're finding the same thing, is that our reach is far broader.
Yeah.
We've been doing things online. Maureen has said many people use Alzheimer's disease as a catch-all for all forms of dementia. Is this a problem?
Yeah, that is sometimes even physicians, sometimes they, without doing more tests to find out, to investigate and find out what is the exact type of dementia. Sometimes physicians just give a blanket statement that a person has dementia, and the most common dementia is Alzheimer's disease. So that is why people, sometimes they might say you have Alzheimer's. But as a consumer, as you can always, you have the right to push for a more definitive diagnosis. Yeah, everyone has that right. So you can say that I'm not happy with this. I want to know what is the cause, exact cause. So let's get some more tests done. And that way you can, if your physician is not complying with your request, then you can request for a referral or even contact the seniors' health. They will make sure that your request is followed up.
And again, your presentation was great, provided valuable information for people to realize there are various levels and there are things that you can do. So that was great help. Louisa said, well, thank you. An anonymous, where can a woman of 75 find support groups related to healthy aging, staying physically active in winter, and developing a support system? Well, I would like to suggest the Kerby Centre is a good opportunity for you there, because we will continue throughout the fall and winter here with our online presentations. We also offer our online fitness classes. I think even our education and recreation is doing some online education classes as well. So, I think that's a good place to start. You might have some other ideas, Padma.
Yes. So my first answer was going to be Kerby itself. And my second answer is the city of Calgary. They have started providing lots of online, fitness, exercise, education, diet, all those kind of, on nutrition and things like that. And another option for you is, it just came to my mind and it just slipped out of my mind at the same speed. Okay, so yeah, it's funny sometimes, you get an idea and by the time you finish sharing an idea, you forgot.
Too many things flashing
yeah.
at the same time. I think age-friendly Calgary.
Yes, age-friendly Calgary city, and also the hospital, South Health Hospital. They've got lots of learning and the why, that is what I wanted to tell you about. YMCA, they've got lots of fitness programs, education, all that online. So you can access anything. If you want to do some stretching, then you can just click that and it's already recorded and you can follow along. If it is aerobics, if it's gentle fitness activities, all that, programs are there, all freely downloadable, freely accessible. So there are lots of options these days compared to the past.
Yeah, and our presentation yesterday, was impressed the importance of isolation and loneliness having an effect on our aging and shortening life expectancy. So it's great that you're reaching out. And Kerby also has a program where we have social calls, so people will give you a call and have conversations. So a great question, and I encourage you to reach out to any of those resources we've talked about. Anonymous also here, if a person with hearing impairment has found many hearing aids painful, what other type of hearing aids are there?
So there are lots of new models that are new versions that are available for people above the age of 50, 55 plus. So that is something to, talk to your physician about it, ask for options that are very small, tiny. So until I met someone who was using an hearing device, and until she took it out and showed it to me, I couldn't even see it because it was so tiny, sleek, and deep, resting in the deep inside the ear that you couldn't even spot it out. It's so small, it doesn't cause any pain or discomfort. So those kind of versions are available. Funding is available also for hearing devices. So I think please talk to your physician about it, and they can take you, direct you in the right way.
Well, and for those people that are interested in the topic, we will be featuring audiology and innovations once again during our Kerby Virtual Expo on Tuesday, November 23rd. And Dr. Scarf will have lots of great information for you on that. So I might suggest keep an eye out on Kerby News. We'll get that information out.
Yeah, she's really great. Dr. Kerby Scarf is really great. She's been working in this field for so many years. Yeah, it's great to have her.
Oops, for whatever reason here, I'm there we go. So we've got a couple of chats. Maureen had to sign out. Mary, could you make closed caption an option for hearing impaired? I missed the discussion. Mary, it's a great point, and it is something that we have been looking into. And so I'm going to make a note here as we move forward with some of our presentations to see if we can investigate the closed captioning on our Zoom presentation. So thanks for bringing that forward.
Yeah, that's a great idea. Yeah.
So with no further questions, we will look forward to seeing you all next time. Padma, again, thank you very much. And
bye.
Take care.